Please take a seat. Okay, so welcome to this educational session on Catatonia, etiology, presentation, assessment and treatment. I think it's great that ECMP chose this important topic. Even though it's a syndrome which was described over a century ago, it still poses a challenge to treating clinicians. So Catatonia stands out for the fact that it's a syndrome which cuts across psychiatric and medical diagnosis. It cuts across scenarios. We can see it in the emergency room, but also in inpatient and outpatient department. We can see it in psychiatric wards, but also in medical wards. And it continues to be one of the few psychiatric presentations which can lead to life-threatening circumstances. So the panel here feels that it might be overlooked many times, or at least in some cases, hence why we think it's a really good idea to go over the basics in terms of diagnosis, assessment, and management. Even though it's been known for a number of years and the fact that it's a really important condition to bear in mind, research in the field has been very slow. However, there have been recent developments in the last years, some of which have been led by the two speakers we have here today, and which I think will be really good to be hearing out about during this session. So, before we proceed with the talks, I do need to remind you that questions must be posed through Slido, through the Slido platform. So we're on day 3 of the conference. You probably all know about Slido, but I do need to remind you about this. This is an educational session, so it's supposed. With no further ado, I would like to present our first speaker. He is Professor Sebastian Walter from Switzerland. He's Professor of Psychiatric Neuroscience at the University of Bern, where he also heads the outpatient department at the University Hospital of Psychiatry and Psychotherapy. His research focuses on brain-behavior associations, particularly in the sensory-motor domain and sensory-motor domain of psychopathology. His research has been funded. He's published extensively in the field and is author of important works on this topic. And he will talk to us today about Catatonia, etiology, and presentation.
Well, thank you for the nice introduction, Giselle. And if you're still looking for seats, there's more on your right over there. And we will start this. I'm very excited to be here. Thank you for the invitation. I will be talking about presentation etiology of catatonia, and here are my disclosures. Some of the fundings have helped to do work in catatonia, and I will also want to direct you to some of the wonderful work that has been done by journalists describing what catatonia is, and there was a very nice article in Vice calling catatonia a mysterious syndrome that turns people into statues, and it includes a lot of catatonia scholars explaining what's going on in catatonia for lay peoples. Now, what is the definition of catatonia? Catatonia is a psychomotor syndrome that includes disturbances of motor behavior and volition, and we will talk about this briefly in a few minutes. And all of this can be modulated by affective states, such as anxiety, for instance. Now, with catatonia, your movements can be increased, much reduced, or broadly abnormal. And we will also look into how that might look like. And please do not forget that catatonia might be associated with autonomous dysregulation, which is very, very dangerous when it occurs, and a big sign that you need to start administering treatment. The duration of the episodes is minutes to years, so very broad range, but mostly several days. And catatonia, and this is the new information for the last, let's say, decade, may occur along with multiple medical and psychiatric conditions, and this has broadened the spectrum of people and also diagnosis where we can suspect catatonia. So this is where a lot of new research will be happening, trying to describe catatonia as a syndrome across multiple disorders. So how about your current knowledge about catatonia? What do you think? What is the gender ratio of catatonia from females to males? Please enter your answers here. So is it 1-to-1? Is it 2 males to 1 female, or the other way around, or 1-to-5, 1-to-10? Can we get the next, please? Oh. Okay, so 1-to-1 is the right answer. You would suspect catatonia across both sexes equally, and it's, yeah, you can, this is, yeah, you're learning very fast, wonderful. So, okay, let's go to the next questions. At what ages would you suspect catatonia syndromes in terms of years? Is it something that is related to childhood? Is it from age 5 to, let's say, 100? Is it something for adolescents and young adults, or something for adults, or something around, let's say, the 40s to the 80s? Please put in your guesses now. Okay, here we are. The right answer is 5 to 100. So there were cases of very young children already, aged 3 to 5 years. It's like the earliest cases of catatonia that the literature is known of. And there are a lot of cases also in elderly homes, so people approaching 100 or even going beyond 100 years of age. So catatonia is something that you must consider across the whole lifespan of people. And again, we see a wonderful steep increase in knowledge here, great educational impact. Now, how does catatonia look like? Well, we will be discussing the presentation in the next slides, and I want to focus here on the way how we approach catatonia. So it's a little bit different from psychiatric practice overall because we want to touch the patient. First thing is you observe, then you get into interaction in terms of the interview, and then you have the physical exam. And you can see here that we have, in the observation, there's opportunities that the motor activity might be increased, abnormal, or decreased. We've summarized this in a sketch here from an article in Lancet Psychiatry, where we listed all the catatonia signs according to the Bush-Francis catatonia rating scale, which has a lot of overlap with DSM-5 and also ICD-11 criteria, which we will touch upon later. But first is you observe the patients, ask caregivers, ask the nurses, for instance, how do people behave? What do you see? Is it increased, abnormal, or decreased motor behavior? When we start the interview, approach the patient, talk to them, we can observe either abnormal or decreased motor behavior. And then when we do the physical exam, there will be instances in which patients have abnormal physical exam, abnormal motor activity. And then along with that, you need to have like your equipment for that. You want to know about the temperature, the heart rate, the blood pressure of the patient, the autonomic abnormalities might be present in any way. Now, how does it look like? The observable catatonia signs, I have some here. Increased activity would be combativeness or agitation and excitement, patients wandering around, having a lot of motor activity. Then there's the abnormal activity, which is depicted here on the right in a photograph of Kraplin's early textbook of psychiatry, a group of patients with catatonia that show posturings and mannerisms and probably also staring. They have these very odd postures, and we can also suspect that some of them might have been brought into these postures using flexibilitas seria, for instance, where the examiner can actually shape how the patient is standing there, and we have a decreased activity signs here of staring or ambitendency. Now, if we go into the interaction, when we see patients interacting, what we can observe is abnormal activity in terms of verbigeration, that is a repetition of syllables or short phrases. We have echolalia, repetition or the imitation of words and syllables, echopraxia, imitation of movements, and then automatic obedience, that the patient does everything that they're being told. Then we have decreased activity like negativism, which is depicted here very nicely in a figure, in a photograph of 1902 textbook by Wilhelm Weigand. The patient is turning away facing the wall, like to prevent the getting in touch, in contact with the examiner, which is called negativism, the turning away here. And then we have mutism, not speaking at all, or social withdrawal. And then in terms of the physical examination, there are some signs that have received a lot of attention, such as the walksy-flexibility, which is depicted here, a person holding up her extremities against gravity in a very, let's say, uneconomic way. If you try this at home, please stop the time how long you can hold that. It's very uncomfortable very soon, depending on your training. But after all, this is something that the patients hold for very long times. It's a significant sign that is very rare, but if you encounter this is very, let's say, very specific, let's say, for catatonia. Other ways are like mid-gain, which means that the patient will follow the movements. Even if you just touch patients like slightly, they will do massive movements, rigidity, the catalepsy or grasp reflex. So we get to the next question here. The patient turns away and closes her eyes when you enter the room. Which catatonia sign is it most likely? Is it stereotypy, staring, catalepsy, negativism, or automatic obedience? Please enter your answers. And then in terms of the physical examination, there are some signs. Question here. The patient turns away and closes her eyes when you enter the room. Which catatonia sign is it most likely? Is it stereotypy, staring, catalepsy, negativism, or automatic obedience? Please enter your answers. Wonderful. Yes, negativism is the right answer. It's exactly what I've shown you on the picture there. Now, the diagnostic criteria of catatonia in DSM-5, the text revision, and the ICD-11 are very much similar, and both are based on clinical epidemiology, on work. In DSM-5, it was 12 signs listed, and those 12 signs came up from a study by Peralta and Cuesta, a group from Spain who was very much knowledgeable in examining catatonia in very early psychosis, and they identified those 12 signs to be predictive of catatonia. And the idea here is that you need a minimum of 3 out of those 12 signs, and then you can say, this is the catatonia syndrome. And then there's multiple ways in DSM-5 where you can classify catatonia, either as a catatonia due to another mental disorder, which would be mood disorders, psychotic disorders, neurodevelopmental issues, and so on, or you can have it as due to a medical condition or not otherwise specified here. Now, ICD-11 changed just slightly by adding 3 more signs. Those are here depicted in gray, because there was new data suggesting that those are also very common, very frequent signs of catatonia. So we have a slightly larger group of signs where you can select from. Again, 3 are the minimum, and then there's multiple ways of classifying catatonia. Similar to DSM-5, you can say it's due to another mental disorder. Then there's the opportunity to classify it as induced by substance use or medication, which is new and other, it's a new way of looking at this. Seeing catatonia as a result of medication or substances, and then secondary catatonia, which means all the other medical conditions that could give rise to catatonia. Most of them are related to disorders of the brain itself or disorders of the body that will affect brain function. Now, as you can see clearly here, there's much more options to diagnose catatonia with the ICD-11 criteria, and this makes the catatonia field a very exciting one in the years to come, because we have based most of our research on catatonia in the context of schizophrenia, because this is where catatonia was held for multiple decades, and much of the research that has been done focus on that type of catatonia. Now we're looking at a very broad spectrum with multiple disorders that could be due or could give rise to catatonia or could be comorbid to catatonia, and will be very interesting to see how catatonia as a syndrome might change depending on the context, and also depending on that could be underlying. Now, another question for you. On this list, those 4 ones, which is the most common condition associated with catatonia? Is it autism? Is it generalized anxiety disorder, bipolar, or ADHD? Might be a tricky one. I don't want you to get into fights afterwards, so this will be a good question to ask afterwards. Yes, bipolar disorder is correct, because bipolar disorder is more common than, or let's say it's a very common, very frequent disorder among psychiatric disorders, and there's a high proportion of patients that experience catatonia at least once during their lifetime, this is something to be considered. Now, the course of catatonia has not received much attention so far, but in ICD-11 we went on to think about the course, and we proposed 3 different course features. One is the catatonia episode, very clearly just the episode in which the patient actually experiences catatonia, that starts within a few hours or days and lasts up to 4 weeks. Now, the 4 weeks are not like a set time, it's just something that we had to come up with by when we defined this. So if it's 5 weeks, that would still be a catatonia episode, of course. Now, there's patients who have recurrent catatonia, similar to mood disorder episodes, that have multiple episodes with remissions in between. And then there's types of catatonia where we see persistent symptoms along for years, and those are typically slow evolving with adolescent onset without any remission, often with a slightly different set of symptoms such as rituals, negativism, stereotypies, and mannerisms. And studies to come will have to show whether this distinction in different course features actually holds true if we span or broaden the span of disorders where we see catatonia. Now, in terms of the clinical association, there has been a very fundamental study led by Jonathan, who will be talking afterwards, in psychological medicine, where they had a very large group of patients examined with catatonia rating scales. And here's some features that you should keep in mind. So the sex ratio, we also already talked about this, 1-to-1, expected in all ages, a very heterogeneous symptom presentation. Remember, you need 3 out of 14, so there's a lot of different combinations possible. And we have heterogeneous underlying disorders that could be giving rise to catatonia. There's a few signs that are being presented by the majority of patients, and this is something that's depicted here on the right. So staring, immobility, and mutism are among the features that are presented by more than half of the patients with catatonia. And then there's other signs that are less frequent. For instance, also voxiflexibility, as you can see here, 18% in a sample of roughly 300 patients with different disorders underlying. So the average stay in inpatient treatment, also that's data from Jonathan, is 43 days in the UK. I think it might be different across multiple countries here, but as a take-home message, the catatonia patient stays longer than the average patient on a psychiatric inpatient treatment. 25% of the patients with catatonia will have multiple episodes, and in patients with psychosis, 20 to 40% have at least one catatonia episode during their lifetime. Now, catatonia may also differ in terms of how it looks like and what you can expect depending on where you're working. So this is something that we summarized last year for the New England Journal. If you have catatonia in the emergency department, that might look completely different than what you can expect at the psychiatric unit, because in the emergency department you will see the most acute forms. And there's three major things that you can see. You can see patients with mutism and stupor, not moving, and typically their relatives will say, this happened this morning or yesterday, and now the person's not moving at all, not talking. You can have people with fluctuating acute signs, specifically in the context of mood disorders or schizophrenia also. And then there's the ones that come with repetitive behaviors, stereotypies, for instance, rituals, in the context of more psychiatric disorders. As a differential diagnosis, you want to rule out acute psychosis, or as a comorbid, the neuroleptic malignant syndrome. Here, the differentiation is the history. You need to know which type of medication was started when. We can see multiple things. You can see patients with on an antipsychotic that get catatonic. You can see patients that are on an antipsychotic and still have catatonia, and so on. There's multiple ways, but please make sure that you know the exact timing of when was the antipsychotic started, when did the symptoms start, what was the presentation before. This is very critical. Intoxications, of course, the anti-NMDA encephalitis, autism and schizophrenia are the typical differential diagnosis in the emergency department. When we come to the medical unit, this is where patients are being taken care of that have the, let's say, the physical comorbidities that we are afraid of in catatonia. Mostly patients with mutism, stupor, and withdrawal, and also the autonomic instability. You would suspect here epilepsy, delirium, encephalopathy, or intoxications, for instance, that need to be ruled out when you want to treat catatonia properly. And in the psychiatric unit, that might be most familiar to most of you, you can see the presentation of the chronic catatonia patients, or also some catatonic deterioration in pre-existing psychiatric disorders. You would expect more staring, ambitendency, echo phenomena, verbigeration, and so on, rituals, particularly in mood disorders, schizophrenia, autism, also dementia and intoxications. So, a typical complication of catatonia is pneumonia, tachycardia, so heart rate above 100, thromboembolism, malnutrition, or all of the above. What do you think? Wonderful. Yes, it's all of the above. You have to fear all of those. This is what can happen to your patients, and this is where we as psychiatrists need to change the way we are working. In terms of catatonia, we need to take action quickly, we need to decide quickly, and we need to have a clear idea of the history. most of the times when you talk about other patients, psychiatrists, we are reluctant to do speedy interventions and speedy decisions. We usually take time, think things over. This is not what you're going to do with catatonia, because you might miss the malnutrition, you might miss the thrombosis, and this can be very dangerous to our patients. So you need to take quick action here. Please consider that. Now, we can use rating scales for motor disorders or motor abnormalities, and we can also use instrumentation to actually describe the motor behaviors that many patients with catatonia have. This is a study we conducted a few years ago, and we analyzed it here for this presentation in a different way. There's 50 patients with psychosis and catatonia here in green, almost 50 with psychosis and who have no history of catatonia, and then healthy controls in blue. And what you can see here is the nice differentiation using expert ratings such as the Bush-Francis Catatonia Rating Scale. We see a clear difference between patients with catatonia, patients without catatonia, and healthy controls. And also in terms of self-report, there is some difference, but it doesn't really differentiate between the patients with or without catatonia. It's only different to the controls. Now, when we go to instrumentation such as actigraphy, that will help to monitor the total physical activity over a whole day, for instance, or the gait velocity. What you can see here very nicely is the differentiation between those three groups. Patients with catatonia move less, they walk slower, and also in terms of fine motor functioning, tests of motor dexterity, where people have to rotate a coin in their dominant or non-dominant hand, we can very nicely disentangle the ones with catatonia from the ones without in healthy controls. So you can measure catatonia very well, and Jonathan will tell you how to assess catatonia correctly. How about the etiology? This is where it gets really complicated, and I have to tell you that we will not be able to comprehensively cover this because there's very little knowledge currently. We need to suspect changes in brain networks, which I will touch upon. There's certain molecules that are more prone to be associated with catatonia. We think about GABA, think about glutamate, think about dopamine. There's a lot of genes that could be involved, but there's very little actually in terms of data what has been associated with catatonia. And inflammation has received a lot of attention lately in terms of catatonia etiology, but there's a lot of work to be done in the next decades. Interestingly, there's only one mouse model I know of catatonia, and what you can see now is a mouse that has posturing, and the mouse is typically moving. Now you put the mouse to this bar and it holds to the bar, and that's atypical. Typically the mouse would start moving quickly, but the mouse doesn't, and then it does. So it's not like the mouse would be permanently impaired in motor function. It's like a temporal impairment and some kind of strains that she sticks to the bar. And this is something that the people who did this mouse work also replicated with other phenotypes, let's say animal phenotypes for anxiety or depression, and interestingly, strains that she sticks to the bar. And this is something that the people who did this mouse work also replicated with other phenotypes, let's say animal phenotypes for anxiety or depression. And interestingly, the mice that had this behavior, they had a deletion in the myelin binding protein, so a protein that is important to actually produce myelin during the neurodevelopment. The interesting part here was that the group that did this actually was targeting then using anti-inflammatory agents, targeting the behavior. Unfortunately, the agent that they tested did not achieve clearance for humans, so there was a substance that was used in oncology. Now, what we have some data on is the motor system abnormalities in catatonia, and particularly in the patients with psychosis. So keep in mind, this is catatonia, but only in the patients with psychosis. And what we see here is typically you have a very tight interaction between the cortical motor areas, such as the supplementary motor area and several others that feed into the primary motor cortex and also feed into the basal ganglia and this feedback loops, including cerebellum and so on. And in catatonia, what we see is abnormalities on the level of the premotor cortex, and then a lot of inhibitory activity within the basal ganglia. And it's depicted here on the right in a paper from 2017, where we showed that patients with acute catatonia have an increase of cerebral blood flow within the supplementary motor area. So the premotor cortex is more active in these patients, and this was replicated by a group in Strasbourg. And you can also see that it's not only in the cortical areas, but there's also abnormalities in the white matter, particularly in the corticospinal tract, where patients with catatonia differ from other patients and healthy controls. And we also found that patients with catatonia have some altered cortical folding that suggests that the vulnerability to actually get catatonia sometime during a lifetime is something that is related to very early neurodevelopment in your first or second year of life. Rated from catatonia, although there is a lot of data showing that it's possible that both conditions overlap. You can have catatonia and delirium in the same patient. You can have patients that only have catatonia or only have delirium. I think we're not there yet to actually say, but if you want to stick to DSM-5 or ICD-11 at this point, it's either or, although we know there's some overlap. So you could consider both, and in terms of the treatment, that might change, the way you want to approach this. And I think Jonathan will tell you about it. It's important that you make up your mind about what it might be the potential cause of the catatonia, and that the underlying cause needs to be treated.
Okay, thank you. So I'll thank Professor Walter. And introduce our next speaker. Dr. Jonathan Rogers is a Wellcome Trust Clinical Training Fellow at the UCL Division of Psychiatry and has recently completed a PhD in neuropsychiatry and epidemiology of catatonia. He's an academic clinical fellow at the Maudsley and a specialty registrar in general adult and old age psychiatry. His work has been reported widely in the media. He's been awarded with many prizes, especially considered the fact that he still has a lot to do in terms of training. But it's a pleasure to welcome him on the stage to talk about catatonia assessment and treatment. Thank you.
Thank you. Thank you so much for the very kind introduction. I'm going to start with a story. I'll take you back about 200 years, 1833 in Vienna. There was a physician called Georg Pfändler, and he was treating a young lady who was depressed. She became mute. She stopped eating and drinking. She was holding bizarre postures, and he was conducting home visits to her. He came along one day, and she was completely immobile. He couldn't see any respirations, and he pronounced her dead. This young lady was buried shortly afterwards, and then the one piece of good luck that this girl had was that her relatives decided to bury her in an expensive dress. And the gravedigger decided that he'd come back later that night to purloin it and sell it on. And he had the shock of his life because this girl was still alive. And of course, she wasn't dead, she had catatonia. That was 200 years ago. This was 1 year ago. Now, in the case on the left, this older lady had catatonia, and because science has advanced, the catatonia was detected before burial at her funeral when she was knocking on her coffin. So my main conflict of interest is that if I get catatonia I don't want to be buried alive. So I'm going to cover two areas. How do we assess for catatonia, and how do we treat it? So, to start with, which catatonia scale has been validated by a lorazepam challenge? The Rogers catatonia scale, sadly no relation. The Bush-Francis catatonia scale, the Nordhoff catatonia rating scale, the Bräunig catatonia rating scale, or the Kanner scale. Excellent. So lots of right answers there. So the Bush-Francis is the only one that's been validated with the lorazepam challenge. The Nordhoff catatonia scale takes a little bit longer to do, but is very detailed, very precise. I use it for research alongside the Bush-Francis. In terms of how you go about using the Bush-Francis, there are two ways you can use it. Either there's a screening instrument, 14 questions, you just rate the features as present or absent. It's not diagnostic. Someone could screen positive on this if they're not responding to external stimuli and they're mute and that they're immobile, but actually they could be in a coma. But it means that you've got to look carefully for catatonia. And then there's the full 23-item part of the Bush-Francis, the full rating scale, where you rate every item between 0 and 3. And I find this super useful for measuring severity and treatment response. Give it before a treatment, give it after a treatment, and you can really see what direction somebody is heading in. How do you assess for catatonia to fill in a Bush-Francis? Well, it's really important, as Professor Walter said, that you don't just conduct an ordinary mental state examination, because you can miss some of the barn door signs of catatonia. And I've examined patients with really classic signs that have been missed because people haven't examined the patient. So, as well as giving a tour de force lecture on catatonia, Professor Walter has also kindly agreed to start his modelling career today and be a subject for a catatonia examination. So, to start with, if I were examining Sebastian, I would aim to observe him indirectly, see how he behaves in the waiting room or on the ward. I then approach him and offer to shake hands. Hello, lovely to meet you. Okay, and and I don't know if you can see, but he's presenting this this ambitendency with these very hesitant movements. Would you mind just turning by 90 degrees? Would that be all right? And he's quite psychomotor retarded as well, you can see. So I try to shake hands with him. If you don't immediately elicit the ambitendency, you can give some conflicting instructions to bring it out. So, Sebastian, don't shake my hand. Okay, and these hesitant backwards and forwards movements you can see there. I then try to engage him in a conversation. How did you get here today, Sebastian? You used the tram, okay. And where are you from?
Switzerland.
Switzerland, okay. And he's answering quite nicely there, but sometimes you get very prominent speech signs, so he might be completely mute, or there might be verbiduration, where he repeats the same phrase again and again like a scratched record. Or there might be echolalia, where he repeats back my speech.
He repeats back my speech.
There we go. And I I then try to elicit echopraxia. So I'd scratch my head in a slightly exaggerated way, and you see that, again, Sebastian imitates it. Often it's a kind of partial imitation, so he might take his hand up like this, and similarly with the echolalia, often he might just repeat the end of my question. I then assess his muscle tone. So, Sebastian, could you just relax for me? I'm going to move your arm about, all right? So I'm going to move his arm around at different joints in a slightly unpredictable way. Okay, that's really helpful. And we'll do the same on the other side. Thank you. Okay. And then I'm going to test for catalepsy. And to do this, Sebastian, I'm just going to take your pulse, if that's all right. So I'd raise his arm up like this, and then for about 10 seconds, I keep it here. And then catalepsy. And to do this, Sebastian, I'm just going to take your pulse, if that's all right. So I'd raise his arm up like this, and then for about 10 seconds, I keep it here. And then I'd let go. Assess his muscle tone. So, Sebastian, could you just relax for me? I'm going to move your arm about, all right? So I'm going to move his arm around at different joints in a slightly unpredictable way. Okay, that's really helpful. And we'll do the same on the other side. Thank you. Okay. And then I'm going to test for catalepsy. And to do this, Sebastian, I'm just going to take your pulse, if that's all right. So I'd raise his arm up like this, and then for about 10 seconds, I keep it here. And then I'd let go. And you can see the catalepsy beautifully presented there as he keeps his arm in that position. Sometimes patients who are just going into or coming out of catatonia, their arm will just very slowly drop down. And it's worth timing how long it stays in that place as well, because it's an indicator of severity. Thank you. And sorry, I haven't quite finished with you yet, but yeah. Then you want to do almost the opposite. So this time, Sebastian, would you mind putting your arms out like this and just keeping them in that position? Don't let me move them. Then just use a single finger to try to elevate his limbs. And he's doing very well at resisting me. One catatonic sign you sometimes see is mitmachen, where even with a small pressure, I'm able to push him up. And in the extreme form mitgehen, I'd apply a small pressure like this, and his whole body kind of falls back like that. Okay. It is worth taking the pulse, as we've mentioned, and occasionally you get this phenomenon of catatonic pupil, where you get a dilated, unreactive pupil. And I'd also check his charts, check his blood pressure, his heart rate, and his oral intake. Thank you so much. Much appreciated. So that's how you examine for catatonia. What else might you do in your assessment? Well, there are all kinds of fancy tests we can do, but I think probably the most useful investigation you can do in catatonia is the lorazepam challenge. How do you do it? Well, you take a patient you think might have catatonia, you do a baseline assessment, ideally something quantitative like the Bush-Frances, and then you administer a bolus of lorazepam. It's better if you can give it parenterally, so intravenous or intramuscular, because A, you get a faster response, and B, that the peak plasma levels just get that bit higher. I tend to get more equivocal responses if you give an oral challenge. And then after a period of time, depending on the route, if you give it IV, you can just reassess 5 minutes later. IM, you want to leave it a little bit longer, reassess the catatonic features and see if it's improved. If it doesn't work, you can give another bolus. What's the point in this lorazepam challenge? Well, there are several useful things it does. Firstly, it tends to be successful in catatonia. So if you get a positive response and you're a bit on the fence as to whether this is catatonia, this provides you fairly compelling evidence that it is. It's not 100% specific, so status epilepticus could of course respond, and occasionally functional neurological disorders, formerly known as conversion disorders, might respond to this, similar to abreaction. But if it looks like catatonia and it responds, it gives you a lot more confidence. Secondly, patients with catatonia, it can be really hard to get a good history, and they often present as these diagnostic conundrums. And sometimes the lorazepam challenge can give you a window of lucidity, where for a few hours the patient is able to reveal more of their story. It tends to be successful in catatonia. So if you get a positive response and you're a bit on the fence as to whether this is catatonia, this provides you fairly compelling evidence that it is. It's not 100% specific, so status epilepticus could of course respond, and occasionally functional neurological disorders, formerly known as conversion disorders, might respond to this, similar to abreaction. But if it looks like catatonia and it responds, it gives you a lot more confidence. Secondly, patients with catatonia, it can be really hard to get a good history, and they often present as these diagnostic conundrums. And sometimes the lorazepam challenge can give you a window of lucidity, where for a fairly compelling evidence that it is. It's not 100% specific, so status epilepticus could of course respond, and occasionally functional neurological disorders, formerly known as conversion disorders, might respond to this, similar to abreaction. But if it looks like catatonia and it responds, it gives you a lot more confidence. Secondly, patients with catatonia, it can be really hard to get a good history, and they often present as these diagnostic conundrums. And sometimes the lorazepam challenge can give you a window of lucidity, where for a few hours the patient is able to reveal more of their psychopathology, and you say, okay, wow, this is psychotic depression, or this is schizophrenia. Suddenly it's clear. And the third reason why the lorazepam challenge is useful is that it predicts a further response to lorazepam. So if they respond to an initial dose of a lorazepam challenge, it's likely that they'll respond to further treatment with lorazepam. A caution is if a patient's on regular benzodiazepines, it's unlikely that this is going to work. What about those other tests? Well, we're trying to do several things when we work a patient up for catatonia. We're trying to rule out differential diagnoses. We're trying to, so that is, if it's not catatonia, what else might it be? We're trying to establish the cause of the catatonia, and we're trying to look for complications of the catatonia. There are a number of conditions which can result in catatonia. Some of the psychiatric ones, as we've heard already, include depression, mania, psychosis, autism. But there's a wide range of neurological and general medical causes. Mark Oldham has this mnemonic, but there's a wide range of neurological and general medical causes. Mark Oldham has this mnemonic mindset, which is perhaps worth committing to memory. Unfortunately, it starts with the miscellaneous category, which is not terribly helpful, but hyponatremia, uremia, sepsis. I'm particularly interested in the literature around CNS inflammation and catatonia, and there are a number of infective conditions. One important distinction from delirium is that in delirium, most of the infectious causes are systemic stomach infections, the chest, urine, or GI infections. Whereas with catatonia, most of the conditions that cause it are primary neurological conditions, so herpes simplex virus encephalitis or HIV encephalopathy. Among the autoimmune and autoinflammatory conditions, by far the biggest one, we did a systematic review a few years ago, out of 350 cases of autoimmune catatonia, 250 were one condition, NMDA receptor encephalitis. So this needs to feature on your differential diagnosis. Of the 100 remaining, 100 of them were neuropsychiatric lupus. Neural injury. There are lots of case reports out there of focal lesions, for example, after stroke causing catatonia. Various parts of the brain implicated. What we found when we've looked at neuroimaging and catatonia more systematically is that most patients with an abnormal MRI have quite non-specific findings. They have generalized atrophy or diffuse white matter lesions. There are three genetic conditions for which there's quite a lot of cases out there on a relationship to catatonia. So Down syndrome, particularly Down syndrome disintegration disorder, this sudden regression in motor and verbal behavioral skills. 22q11.2 deletion syndrome, DeGeorge syndrome or velocardiofacial syndrome, and Phelan-McDermid syndrome, which is due to a problem with the SHANK3 gene on 22q13. Phelan-McDermid syndrome actually features periodic catatonia, that classic guessing middle of the last century disorder, and it also features epilepsy and learning disability. Structural CNS pathology, brain tumors, for example, have been implicated in catatonia. And there's a really interesting relationship to epilepsy. So non-convulsive status epilepticus can present with catatonia. And there's also postictal catatonia. So sometimes you have a seizure and then in the days afterwards you can get catatonia. Of course, paradoxically, we're going to talk later on about ECT, electroconvulsive therapy, as a treatment for catatonia. The other interesting thing in the relationship between epilepsy and catatonia is that there are a number of conditions where it looks like there's interictal catatonia. So there's catatonia and there's seizures, but without a clear temporal relationship between them. Lots of cases of intellectual disability, including Down syndrome, Phelan-McDermid syndrome. NMDA receptor encephalitis has catatonia very commonly and seizures very commonly. And then toxins and medications. Again, I'm just highlighting some of the most common conditions that I see and that are in the literature here. So use of cannabinoids, particularly synthetic cannabinoids, tacrolimus, corticosteroids, CNS stimulants. And then one of the most common reason I see catatonia is withdrawal from medications. Benzodiazepines and Z drugs, particularly if they've been given as a treatment for catatonia, if suddenly withdrawn, can precipitate a resurgence of the catatonia. But equally, sometimes just patients who've been on long-term benzodiazepines that have suddenly been stopped. And this really highlights the importance of taking a forensic medication history in patients with catatonia. I've had a number of patients where the cause of the catatonia seemed really obscure, no prior medical condition that could account for it, no major psychiatric history, but when you look back in their notes, actually, just a couple of days before the catatonia started, the pregabalin was stopped, for instance. Clozapine is one to be very aware of if you treat patients with psychosis. Some of the most florid cases of catatonia I've seen have followed sudden clozapine discontinuation by 2 to 3 days. And the treatment there is, if at all possible, to restart the clozapine. Actually, some of the other treatments for catatonia don't seem to work that well in this group. And alcohol withdrawal, as well as the delirium tremens and the seizures you can get. Catatonia is a rare presentation of alcohol withdrawal. There was the brilliant question earlier about differential diagnosis of catatonia, and I'll go into that in a little bit more detail. As someone alluded to, hypoactive delirium is in practice often, particularly in a consultation liaison psychiatry setting, a really prominent differential diagnosis. How do I distinguish them? Granted, there's probably some overlap. There are a couple of things. The first is the level of arousal. So although patients with catatonia might superficially look like they're asleep, actually it's a state of sympathetic hyperarousal. They tend to be anxious, they tend to have dilated pupils, be tachycardic and sweaty. Whereas in delirium, these are the patients who fall asleep while you're speaking to them. They're struggling to keep their eyes open. You need two nurses to sit them forward to listen to the back of their chest. So that's number one, the level of arousal. Number two is the more positive signs of catatonia. So the posturing, the mannerisms, the stereotypies that you tend not to get in delirium. And then number three is the lorazepam challenge. And you see a beautiful dissociation in the lorazepam challenge. Whereas in catatonia, it seems to wake the patients up. In hypoactive delirium, they just go to sleep. So hypoactive delirium, really important differential. I think one that can be made clinically. Extrapyramidal side effects, there's some overlap with the increased muscle tone and sometimes the hypomimia you get. Akinetic mutism, which is due to lesions of the mesial forebrain. You can get in stroke, for instance. Stiff person syndrome, I'll just touch on. It is rare. It makes catatonia look pretty common, but it's a really important differential because actually it most commonly presents to psychiatrists. And it presents with muscular rigidity, muscle spasms, and severe anxiety. Muscle spasms and severe anxiety. And it's a treatable autoimmune condition made famous more recently by Celine Dion. Parkinson's disease, in its more advanced stages, can look a lot like catatonia. And there are various neuropsychiatric manifestations of Parkinson's disease. Here, I think that the crucial differentiating feature is the longitudinal course. So Parkinson's disease develops gradually over months to years. Catatonia, people tend to develop over days to weeks. I'm just going to touch on the last item on the list of elective mutism and malingering. This is a big issue in clinical practice. Clinicians often tell me they're concerned about this, but it hardly features at all in the research literature. Where there have been case reports, it seems to have been that the distinction has been made once a patient's been admitted to hospital and they've had really good psychiatric nursing evaluation over a couple of weeks to look for inconsistencies in their symptom and simulation of symptoms. Sometimes it's been in the context of benzodiazepine dependence. So, we've talked a little bit about why you might want to investigate someone for catatonia. Let's talk about the physical examination. And here, some of the more boring aspects of the physical examination are some of the most crucial. Catatonia can result in dehydration, malnutrition, venous thromboembolism. Looking for volume status, are their mucous membranes dry? What's their skin turgor like? Is there a drop in their postural blood pressure? Is very helpful. If you're considering electroconvulsive therapy, they'll need a cardiovascular examination. I listen to the chest of all my catatonic patients, and partly that's to check that they don't have some serious respiratory problem before I give them benzodiazepines. And partly it's because patients with catatonia are at risk of aspiration pneumonia. I can guarantee you that your medical and emergency medical colleagues will not be aware of this when they're admitted to hospital with pneumonia, and it may well affect the antibiotics they receive, so do pass that on. In terms of the gastrointestinal system, look for their nutritional status. Are they wasted? If they've got a nasogastric tube in place, make sure it's in the right place. A neurological examination, look for any focal signs that might be localizing. Look for Parkinsonism and other extrapyramidal side effects. And possibly that the most important item on this list is the musculoskeletal system. Deep vein thrombosis occurs in catatonia. And there have been lots and lots of cases of fatalities due to DVT becoming pulmonary embolism. There was a study in the US just a few years ago which found that a third of preventable deaths in US psychiatric hospitals are in the context of catatonia. Muscle contractures, which can really delay recovery if they're not treated. And pressure sites. In general hospitals, nurses are constantly checking pressure sites. So this is the occiput, the shoulder blades, and the small of the back. In psychiatric hospitals, we're not nearly aware enough of this, and there are cases of horrendous pressure sores in patients with catatonia. Check for urinary retention as well, and occasionally patients with catatonia need catheterizing. That's the physical examination. What about investigations then? Physical observations are helpful. A fluid chart is essential. But beyond that, when we wrote the British Association for Psychopharmacology guidelines for catatonia, we really felt it was important not to give a blanket list of investigations that everyone with catatonia should have. I mentioned clozapine withdrawal catatonia. When I've seen clozapine withdrawal catatonia before, they stopped clozapine 2 days earlier. I don't say, let's get an MRI and an EEG, let's get neuronal autoantibodies and CSF. I say, just restart the clozapine. Let's just crack on with treatment. We've got a clear cause for it. Sometimes there are much more cryptogenic cases of catatonia, and they need a much more thorough workup. So blood tests, thyroid function tests, HIV and syphilis serology, B12, folate, some medication levels, if they're on, say, valproate or clozapine. Anti-nuclear antibodies is a screening test for lupus. Anti-double-stranded DNA is more specific but less sensitive. If there's any suspicion of drug misuse, a urine drug screen. Urinalysis can be helpful in identifying dehydration. An ECG, neuroimaging, a lumbar puncture, including looking for neuronal autoantibodies, and an EEG. I very often get asked the question, is this case of catatonia in front of me, or organic or neurological? And I'm afraid that there's no clear single answer to that question. A thorough workup is helpful. A really detailed collateral history. I recall one patient where the cause of the catatonia really wasn't very clear until we sat down with the relatives and took a detailed history, and it transpired that actually he kept a diary over a couple of years, and there's clear evidence of paranoid delusions in that diary. And consider some of the likely precipitants, some of the big causes of catatonia: clozapine withdrawal, benzodiazepine withdrawal, acute drug intoxication, NMDA receptor encephalitis. And then, of course, actually one of the beauties of catatonia is that you don't need to know the underlying cause to treat symptomatically for catatonia. You can treat first and then see what's left. And sometimes that helps with the diagnostic process. In terms of the EEG is helpful but not conclusive. It's helpful if you get interictal epileptiform discharges. It's obviously helpful if it shows non-convulsive status epilepticus. It's helpful if you get focal findings anywhere, and it's very helpful if you see the extreme delta brush pattern that goes with NMDA receptor encephalitis. When it's not helpful is when it shows generalized background slowing. We did a meta-analysis a year ago. We found actually a quarter of primary psychiatric catatonia cases have generalized background slowing on their EEG. So that's the assessment of catatonia. Let's talk about the treatment. There are 3 strands to the treatment. There's a supportive therapy on the left-hand side here. On the right-hand side, there's treatment of the underlying disorder, and then we've got these specific treatments for the catatonia in the middle, benzodiazepines, ECT, and some other treatments. Supportive therapy, I've talked about some of the complications. Dehydration, consider prescribing oral fluids on the drug chart as a prompt to your nursing staff. Malnutrition, consider dosing lorazepam 30 to 60 minutes before meals to try to optimize their clinical state when they're eating. Pressure sores, make sure patients are being moved around, you're checking the pressure sites. Muscle contractures, make sure patients are being moved to the full extent of movement at each joint. Venous thromboembolism, patients who are immobile for more than a day or two need to be on low molecular weight heparin. And make sure that patients who've previously managed medical comorbidities like hypertension and diabetes are getting the support they need to go on managing them. We've mentioned aspiration pneumonia and urinary retention. Right, on to the mainstay of treatment for catatonia. Why is lorazepam the preferred benzodiazepine for catatonia? Is it because it's the only one that works? Is it that it's got a short half-life? We've got experience of using it at high doses, it's got immunosuppressant properties, or that it has a unique mechanism at the GABA-A receptor. So I was told to make the questions hard, and it seems we might have achieved that. So it's actually, we've got experience of using it at high doses. It doesn't have a particularly unique mechanism at the GABA-A receptor. And in fact, diazepam seems to work in catatonia, clonazepam seems to work. Actually, the Z drugs work in catatonia. And more than that, the barbiturates work, and the Russians even used to use intravenous brandy for catatonia, and it apparently worked. I'm not advocating that, off-label. So we use lorazepam because we've got experience of titrating it up to high doses. If you're giving a lorazepam challenge, it's worth giving it IV or IM. If you're giving treatment for lorazepam at higher doses, it doesn't really matter what route you use. How high should the treatment dose of lorazepam be? Glad to hear lots of whispering and conferring. Yeah, I think you're on the money here. I've had patients who've responded to 4 milligrams of diazepam, of lorazepam, sorry, and I've had patients who've required 24 milligrams of lorazepam. One of the extraordinary things about lorazepam is that not only do some patients require high doses, but they also tolerate high doses. Some patients don't. They'll become sedated before they're treated, and those are the patients where you need to be thinking about ECT. So I tend to start treatment at 3 to 4 milligrams a day and increase the dose by 2 milligrams each day. Every day I'm monitoring for efficacy. Are they better already? We don't need to increase any further. Are they starting to get sedated? And we obviously don't want to increase beyond that dose. And you want to continue treating until the underlying disorder is being treated. So you want to address the depression or the mania or the psychosis or the encephalitis or the epilepsy. How should you stop lorazepam for catatonia? Okay, lovely. Yeah, so D is correct. You want to wait until you've got the catatonia under control, and then you can titrate down. How quickly you titrate down depends a little bit on how long they've been on the benzodiazepines. So to give parameters on this question, we know that stopping lorazepam suddenly can lead to a resurgence of catatonia, or even worse, I've had a case of benzodiazepine withdrawal seizure where the lorazepam was stopped precipitously. On the other hand, there was a clinical trial back in the late 90s of long-term lorazepam for long-term catatonic features, which actually found no benefit. So probably a compromise is to wean off gradually over a couple of weeks. You might be able to do it a bit faster as an inpatient or a bit more slowly in the community. It depends what kind of dose you've got up to as well. Electroconvulsive therapy for catatonia. You can use it as an alternative to lorazepam. Use it with malignant catatonia. It can be an emergency treatment. I was speaking to Sebastian beforehand, and he said he can get ECT within 1 hour. I'm very jealous because for us it's kind of 1 to 2 weeks. So how much you use it as an emergency treatment depends a little bit on your local setup. Certainly for treatment resistance where lorazepam isn't working. If your original lorazepam challenge test doesn't work and you still think this is catatonia, I think that's probably the time to start thinking about ECT. You might want to try titrating the lorazepam up further, but in the meantime, get ready for ECT. One really practical question is when you've titrated a patient up to, say, 12 milligrams of lorazepam, they've become a little bit sedated, and you decide to bring it down to 10 milligrams. You think, well, we can't increase it any further, the patient's still got catatonia, so we're going to refer to ECT. How does the ECT work when they've got 10 milligrams of lorazepam on board? How do we get a seizure? Well, we've got a few options. You can increase the ECT dose. That's probably the most prosaic option. You can omit the morning dose of benzodiazepines, or you can reverse the benzodiazepine at anesthetic induction with flumazenil. In case of treatment resistance, which treatment should not be tried for catatonia? So if benzodiazepines and ECT haven't worked or aren't available, which of these options is not a sensible thing to use? The answer is actually tetrabenazine. No evidence that tetrabenazine works and it can trigger catatonia. Levodopa probably works, it just makes them more psychotic. Other antipsychotics probably have a role in patients who have psychosis. Clozapine's got some evidence in more chronic catatonia. Amantadine we use in treatment-resistant cases. So treatment-resistant cases, the evidence is weak, little bit of evidence for atypical antipsychotics, but be cautious. Why are we cautious with antipsychotics in catatonia? And people are completely on the money here. Catatonia is an extremely strong risk factor for neuroleptic malignant syndrome. The paper from Japan, Funiyama and colleagues a few years ago, that found among patients with schizophrenia, if you've got a history of catatonia, your odds ratio for getting neuroleptic malignant syndrome is about 80. And we just never see odds ratios like that in psychiatry research. So if you are going to use antipsychotics, I suggest use lower potency antipsychotics, lower doses, monitor carefully. What are the key points then? As you saw, a catatonia examination just takes 5 minutes. A lorazepam challenge is often more useful than lots of investigations. Treat the underlying condition, whatever that is. High doses of lorazepam are sometimes required, and be cautious with antipsychotics. In terms of further resources, we've got the British Association for Psychopharmacology guidelines, which you can freely access online, and we have a catatonia website here with information for patients, clinicians, and their carers. Thank you.
There are from the audience are really overwhelming. I must say that many of them have already been answered by the talks, which I think is a really good sign. It means that you guys have touched on things that, on questions that were really of interest to people. So, although quite a few people are getting up, we do have 7 minutes for questions, okay? So, what we don't cover now, we can, maybe people can approach you guys after the talk, over lunch. So one of the questions with those supports is whether the superiority of lorazepam over the rest of the benzos, why? Is it only a level of evidence, or is there a superior intrinsic effect of lorazepam? You answered that question, but I think it's really important to clarify, to go over that concept, because some people talk about not having lorazepam available in the hospital. So it's important to bear in mind. There's a question about whether zolpidem has also been tested. So would you like to comment on that?
Yeah, absolutely. My view is that it purely comes down to the pragmatics, really. Lorazepam, as I say, is good because we've got multiple formulations and routes we can give it through, and we've got experience of titrating it up to very high doses. We don't have that experience with, say, diazepam or clonazepam. However, in Japan and China, there are studies showing great results with intravenous diazepam, and in France, there have been studies using oral zolpidem, which has worked very well. So I suspect there is nothing unique about lorazepam in terms of the mechanism.
Okay, great. There are many questions about the differential diagnosis with autism. You know, I asked you before, but I'll think that they've still been coming in. For example, a person with autism can have mannerisms, stereotypy, mannerisms, rituals, and mutism as part of their autism. I would say that they have catatonia only if the symptoms are new or as part of a loss in function. Can you expand on that, on how we would, at what point someone with autism, especially if there's poor report or they're nonverbal or they already have baseline motor symptoms, how we would diagnose catatonia on top of their baseline presentation?
Yeah, so I agree with the person who asked that question, actually, that there is. So I agree with the person who asked that question, actually, that there is a great deal of overlap in the features of autism in terms of the awkward postures, the stereotypies, sometimes even the mutism that you get in catatonia. And so you want to be looking for a step change, a change in function. And there was a Lancet Psychiatry paper addressing this a year or two ago, arguing that actually when you're calculating the Bush-Francis score for these patients, you should subtract their baseline score to give a measure of what's new for them.
Okay, and could you, either of you, talk about your experience with memantine, amantadine, when ECT, benzos, lithium or clozapine have failed?
Okay, so amantadine and memantine don't work quickly like lorazepam. You won't see a result within minutes. They tend to work over a few days. The case report literature seems to suggest that they are universally effective. When I speak to other clinicians, we've got much more mixed results. I think they probably work in some people. The evidence is very weak, though.
We would not stop ECT, just go on with ECT and hope, because there's, the chances that you can actually improve patients that are very worse, are very low. So we would just continue treatment and do not stop something that potentially helps. So adding would be something considerable.
Okay. And another question which has come up a lot is the differential diagnosis from neuroleptic malignant syndrome from Catatonia. How we differentiate? What are the definings, the features which distinguish the two conditions, if they are really two different conditions, right?
I think it's critical here to have the history of the patient. In terms of clinical signs, there's nothing that actually separates catatonia from neuroleptic malignant syndrome, because you can have catatonia with severe rigor that always was proposed as one of the hints that would turn you into neuroleptic malignant syndrome. Many cases that are referred to us with the hypothesis of neuroleptic malignant syndrome turn out as poor history taking in patients with catatonia. It's one thing that the neuroleptic malignant syndrome is very rare. Catatonia is more, let's say, more frequent, but it's hard to detect. You need to know the history. One thing that the neuroleptic malignant syndrome is very rare. Catatonia is more, let's say, more frequent, but it's hard to detect. You need to know the history of the medication, as Jonathan pointed out. You need to know when did they start the antipsychotic, how was the patient before the antipsychotic was started, and how did the symptoms evolve during the treatment? Were there any changes in the administration? Were there changes in the dosage and so on? This is all important. You need to include this, and then you can make very good predictions of what it is.
Okay, and in relation to that, there's questions about how to reintroduce antipsychotics of catatonia. So some people are asking, should you keep antipsychotics at the same dose? Should they be removed? How to reintroduce them? So what are the general guidelines on management of antipsychotics when we suspect it's catatonia related to a primary psychotic disorder?
Yeah, so I think antipsychotics probably do not have a substantial role in catatonia where there is no underlying psychosis. If there is underlying psychosis, they wouldn't be my first-line treatment unless it's clozapine withdrawal catatonia, in which case I'd restart the clozapine. I might use them as an adjunct, and I might use them to treat the psychosis driving the catatonia. If an antipsychotic's been stopped, would I restart it? Well, I restart it to treat the psychosis. I do it a little bit more cautiously than I would otherwise, and I'd observe them quite carefully.
And some people suggest that you should use more clozapine in these patients because it's more likely to help with the catatonia and the psychosis in the psychotic patients. But we need to keep in mind that there's very little data on this. This is much driven by experience and anecdotal reports.
Okay, well, thank you so much. Just to try and be on time, thank you so much for the two speakers.